Next amendment, Mr. Rogers.
Thank you, Mr. Chairman. I have an amendment at the desk. I believe it's listed as 319. Correction, it's Rogers 1, also known as 319.
Will the clerk report the amendment?
Amendment offered by Mr. Rogers of Michigan.
Without objection, the amendment will be considered as read. Gentleman from Michigan is recognized on his amendment for 5 minutes.
Thank you. This is, again, a very, very simple amendment. It follows along what Dr. Gingrey had offered earlier on best practices, and I think gets to the heart of many people's concern about a government-run plan. And I think we can all agree that comparative effectiveness research can be a useful resource for doctors and patients, but it should not be used as a tool to limit coverage or deny treatments. This bill creates an entire new federal regime to conduct comparative effectiveness research, and alarmingly, the bill in its entirety has no restrictions on how the federal government can use that research. None. This is a dangerous open-door policy that will almost certainly lead to CE research being used to make coverage decisions. Here's what comparative effectiveness can teach us. What treatments are generally more effective than others? Which procedures might work better for a particular disease than others? On which drugs have a bigger impact on treating one disease over another? All good things to have in the quiver of a doctor trying to make a decision. But this is important. That research is about general average assumptions. It can't determine anything about an individual patient with a unique condition in need of a unique treatment under the care of a unique provider. These decisions must be left to a patient and their doctor. With comparative effectiveness used as more resource, not a coverage mandate. And there's been lots of examples. I gave you my personal example in the previous debate. There was also recently a 46-year-old Montreal woman who was denied access to a particular cancer treatment that would keep her alive as she battled an inoperable form of colon cancer, and she was trying to prolong her life. This is a standard treatment in the United States of America. But Canada denied treatment, and here's what their ministry said, and I quote, because they wanted to see more prolonged survival rates, end quote. So the government made the decision, based on costs through things like comparative effectiveness and best practices, that they didn't want to spend the money. Now, the doctor was there, the family was there, the Canadian government. And if we don't put protections for doctor-patient relationships in this bill, it will happen as sure as we are sitting here. And people like me won't survive, this woman won't survive, and you'll have the cancer rate survival rates drop, just as they have in the United Kingdom and Canada. We can always find these tragic stories, but I tell you what, these patients deserve better, and they deserve the protection of a uniquely American system that will not ration care. So if you believe we shouldn't be rationing care and we shouldn't be using these things to control costs at the lives and expense of our patients and their families, then this is a simple amendment of which we ought to adopt and adopt quickly. My amendment would ensure that research conducted by the bill's new task force for clinical prevention services and the Agency for Healthcare Research and Quality couldn't be used to determine coverage decisions for patients. This common sense protection must be included in the bill. Only doctors and patients should make these decisions about the treatments that are best for them and not a government bureaucrat. And with that, I would yield back the remainder of my time, Mr. Chairman.
Gentleman yields back the balance of his time. Further discussion on this amendment? Mr. Murphy.
Thank you, Mr. Chairman. I certainly understand the talking point coming from the other side about the skepticism on information produced by the government relative to coverage decisions. But the gentleman's point about not wanting that information to inform a denial of coverage just isn't what this amendment does. This amendment bans any public or private insurer from using that information to evaluate coverage decisions. So it basically says you can't use that information to deny, but you also can't use that information to add either. So let's think of a fairly routine scenario in which this agency that we're talking about here today makes a recommendation for a new preventative service that is an important addition to the standard of care, a new way to screen for cancer, for instance, something that government agencies today, the CDC, the NIH, do all the time. Let's imagine that this agency makes that recommendation. If you are a medical professional running a public plan or a private plan under this amendment, and you happen to read that report, you are deemed illegally making decisions based on adding that new service to your plan if you happen to have read the government report. I have no idea how you'd even enforce this. I think it's a dangerous policy to basically say that if a government agency, this one in particular, makes an important recommendation to add or supplement a particular procedure that the insurance company can't do it, but I have no idea how you'd actually make this enforceable. How would you find out whether a individual running a private insurance plan as part of their decision-making process to add an important new screening provision took into their consideration, even 10% or 20% of their decision-making, the fact that they read some report from this Task Force on Clinical Preventative Services?
Will the gentleman yield?
Certainly.
Thank you. I'm not sure what amendment you're reading. I hope you read mine. It's pretty short. It's paragraph long. But it clearly states in this amendment that it is only not to be used for supporting or developing by the task force, and let me get the exact words here, to account any coverage determination or used to evaluate any coverage requirements. In other words, you cannot say, you can't use comparative research to figure out what will or what will not be reimbursed, and you can't use it to set reimbursement levels. That's very clearly different from what the gentleman is saying. Again, I wouldn't oppose that you have to do the research and keep it secret. That would defeat the purpose of the research, and I happen to think the research is a good thing. But what we need to do is make sure that they don't use a good thing in general terms to punish patients and doctors in their relationship by setting reimbursement rates and what is and what is not covered. And that's very simple in the
reclaiming my time, I guess I just don't read the phrase used to evaluate any coverage requirements as only applicable to coverage denials or limitations. I think when you use a phrase as broadly defined as evaluating coverage requirements, that certainly could be read by someone setting up a private or public insurance reimbursement plan to prohibit them from using this information to make additions.
Well, gentlemen, if we did unanimous consent to strike, evaluate, and put deny, would that help the gentleman?
Reclaiming my time, I think the underlying concern here is that to the extent that there is a fear that the underlying bill would lead to these denials being made on the information coming from these new agencies, in particular this Task Force on Clinical Preventative Services, I just encourage my friends to read the bill. There is absolutely no enforcement mechanism right now in the underlying bill, so even if this was drawn as a limitation on denials, I don't think it's necessary. Mr. Chairman, I'll yield back the balance of my time.
Gentleman yields back the balance of his time. Ms. Myrick?
Thank you, Mr. Chairman. I just wanted to speak in support of this amendment, and actually I think Mr. Barton's suggestion of changing the word to deny is a very reasonable one. But as a cancer survivor myself and someone who works all the time with cancer patients, everybody's different. And I would hate to see I support comparative effective research is a good thing, but I would hate to see that used in any way in being forced to make decisions on a particular person and their case. So I just wanted to add that to the discussion, and I would hope that the chairman might consider that word if it would make a difference in the amendment. And I yield back.
Further debate?
Mr. Chairman.
Mr. Braley.
Mr. Chairman, I want to strongly oppose this amendment, and I think it's important for everyone here to understand that the Prevention Task Force, defined on page 944 of the bill under section 3131, doesn't do comparative effectiveness research. It doesn't do any primary research at all. And in fact, over 20 years, the U.S. Preventative Services Task Force has built a reputation for impartial, science-driven recommendations about what works in prevention. And I want to emphasize again, the task force does no original research. It merely reviews the scientific literature to determine what works in prevention. The amendment that's being offered would prevent any insurance company from considering the recommendations of the task force. It would limit the ability of insurance companies to cover things like breast cancer screening, cervical cancer screening, colorectal cancer screening, all of which are currently recommended by the task force. Finally, the amendment seeks to solve a problem that doesn't exist. Medicare can extend coverage to services recommended by the task force, but it cannot deny coverage to services that aren't recommended. The new Benefits Commission must cover task force recommendations, but may cover any preventative service. This bill does create a new permanent center for comparative effectiveness research in Division B of this bill, which we are not debating right now. We should have a debate about comparative effectiveness research. I look forward to it. That debate, however, should belong where it belongs, and that's in Division B. It shouldn't happen in the context of the clinical task force, which simply doesn't engage in any of the sort of comparative effectiveness research that is the subject of this amendment, and I'll yield back.
Gentleman yields back the balance of his time. Mr. Terry.
At this point, I'd like to yield to Mr. Rogers.
Thank you, and I appreciate the gentleman's argument. I just want to refute you, and why this, I think, is so important to building these protections for patients and doctors, as it clearly states under page 937 under the prevention task forces that they will review the scientific evidence related to benefits, effectiveness, appropriativeness, and costs of clinical prevention services identified under this paragraph. They clearly use the science that's based on that. And if we don't build in the protections, I guarantee you, as they have done in every other government-run healthcare system in the world, they use it to ration care. Let's just build in the protections. We're all agreeing on the same thing. Research is good. And in a general sense, doctors should have it available as soon as they can get it in their hands. But they shouldn't put it in the hands of the people who are going to make the determinations if you can have it or not based on what your cost is or by what some artificial standard is, so that some people, as they have in every other country, maybe even here, could have fallen through the cracks.
Gentleman from Michigan, yield to me.
I'd yield to, who's seeking recognition?
I have the time. I'll yield to you.
Yeah.
Mr. Chairman, you wanted to yield?
Oh, Mr. Terry, you had.
Yeah, I
yes,
had the
thank you.
time.
Well, I was reading the language, and it says, take into account in any coverage determination. So if there's effectiveness research that indicates that there ought to be a service covered, that would be prohibited? That seems like a strange conclusion. Or evaluate any coverage requirements. Suppose we think that there ought to be a certain screening program to prevent a disease, and the private insurance companies want to take that research and provide that additional coverage. You were talking about denying coverage, but this would also deny new coverage as it may be determined. And then determine or evaluate reimbursement levels. Well, I don't know. That would be something I think makes some sense. But the others, if you read them literally, could have exactly the opposite effect of what you've argued.
Reclaiming my time and yielding to Mr. Rogers
And I think
as your moderator for the day.
And what I think worries me most about your comment there, Mr. Chairman, is you said you don't have any problem with reimbursement rates. That's exactly what gets the other countries in trouble, right there. And why we ought to put this protective language in the bill, and it doesn't do it proactively. It says you can't go back and say, I am not going to cover bladder cancer for a 19-year-old because it doesn't fit the profile. What it does say is that we will provide coverage in association. It doesn't prevent that in any way, shape, or form because there are unique circumstances. And so you're trying to take comparative effectiveness and lay it over into individual cases in this bill. That's what you try to do, and it will happen in this bill. And what we're saying is comparative research is good, but don't use that as your template to set up what coverage reimbursement, which you say you don't have a problem with. Fundamentally, I have a huge problem with that. I think that's what inhibits doctors.
Well, Mr. Terry, yield to me further.
I would yield back to Mr. Terry.
Yes, reclaiming my time and yielding to the chairman.
Thank you. Well, I don't want to say that I'd never be for determining reimbursement levels, but I don't think we're anywhere near this sort of thing. I think comparative effectiveness ought to be to advise people on the latest research to see what's effective. I don't think we ought to be talking about reimbursement levels, but it could well be that if you find some medical procedure that is just ineffective, and we know it's ineffective because it's outdated, why shouldn't an insurance company say that we're not going to pay for it any longer? I think that's a reasonable approach. I wouldn't want to say they couldn't even use it for that. So I just think that whatever you're trying to accomplish, it's too broadly drawn and might be counterproductive. So I just want to point out those reasons why I would oppose this amendment.
Would Mr. Terry,
Yes, I would like to yield to Mr. Barton.
in his supreme moment of controlling the entire debate in the Energy and Commerce Committee, yield to the ranking member? You know, time after time in this debate so far, Mr. Chairman, Republicans on the committee have taken the majority at their word. We've read the bill, we take the plain language, and if we see an anomaly or a problem, we've offered amendments to try to correct it so that the bill actually reflects what we take at face value is the intent of the majority who's drafted the bill. And that's what Mr. Rogers is doing. And y'all appear to be opposing him because you apparently don't really believe the language in your bill. You really want it to do something else. But when we try to limit it to what you say you want to do, you oppose it. You know, comparative research is about research. You know, if you believe in transparency and you believe in the market and you believe in people having the appropriate amount of information, making the appropriate decision, all you've got to do is publicize the comparative research, and the healthcare community will take it from there. You don't have to put mandates. You don't have to make decisions that limit free choice and free will in the public healthcare marketplace. And that's all Mr. Rogers is attempting to do. He's taken the majority who drafted the bill at their word. So I would support the Rogers amendment. And I thank Mr. Terry for yielding.
Are we ready for the question? Any further debate on this amendment? All those in favor of the amendment offered by Mr. Rogers of Michigan will say aye. Aye. Opposed, no. No. Well, we're probably going to have a roll call vote. We might as well get to it.
Mr. Waxman?
No.
Mr. Waxman, no. Mr. Dingell? Mr. Markey? Mr. Boucher? Mr. Pallone? Mr. Pallone votes no. Mr. Gordon? Mr. Rush? Ms. Eshoo? Ms. Eshoo votes no. Mr. Stupak? Mr. Stupak, no. Mr. Engel? Mr. Engel, no. Mr. Green? Ms. DeGette? Ms. DeGette votes no. Mrs. Capps? Mrs. Capps, no. Mr. Doyle? Mr. Doyle, no. Ms. Harmon? Ms. Harmon, no. Ms. Schakowsky? Ms. Schakowsky, no. Mr. Gonzalez? Mr. Gonzalez, no. Mr. Inslee? Mr. Inslee, no. Ms. Baldwin? Ms. Baldwin votes no. Mr. Ross? Mr. Weiner? Mr. Weiner, no. Mr. Matheson? Mr. Butterfield? Mr. Butterfield, no. Mr. Melanson? Mr. Melanson, no. Mr. Barrow? Mr. Hill? Mr. Hill votes no. Ms. Matsui? Ms. Matsui, no. Mrs. Christensen? Mrs. Christensen, no. Ms. Castor? Ms. Castor, no. Mr. Sarbanes? Mr. Sarbanes, no. Mr. Murphy of Connecticut. Mr. Murphy, no. Mr. Space. Mr. Space, no. Mr. McNerney. Mr. McNerney, no. Ms. Sutton. Ms. Sutton, no. Mr. Braley. Mr. Braley, no. Mr. Welch. Mr. Welch, no. Mr. Barton. Mr. Barton votes aye. Mr. Hall. Mr. Hall votes aye. Mr. Upton. Mr. Upton, aye. Mr. Stearns. Mr. Stearns, aye. Mr. Deal. Mr. Deal, aye. Mr. Whitfield. Mr. Whitfield, aye. Mr. Shimkus. Mr. Shimkus, aye. Mr. Shattuck. Mr. Shattuck, aye. Mr. Blunt. Mr. Blunt, aye. Mr. Boyer. Mr. Boyer, aye. Mr. Radonovich. Mr. Radonovich, aye. Mr. Pitts. Mr. Pitts, aye. Ms. Bono-Mack. Ms. Bono-Mack, aye. Mr. Walden. Mr. Walden votes aye. Mr. Terry. Mr. Terry, aye. Mr. Rogers. Mr. Rogers, aye. Mrs. Myrick. Mrs. Myrick, aye. Mr. Sullivan. Mr. Sullivan votes aye. Mr. Murphy of Pennsylvania. Mr. Murphy votes aye. Mr. Burgess. Mr. Burgess, aye. Ms. Blackburn. Ms. Blackburn, aye. Mr. Gingrey. Mr. Gingrey, aye. Mr. Scalise. Mr. Scalise, aye. Mr. Rush. Mr. Rush votes no. Mr. Boucher. Mr. Boucher votes no. Mr. Dingle. Mr. Dingle votes no. Mr. Matheson. Mr. Matheson. Mr. Matheson votes no. Mr. Green. Mr. Green votes no. Mr. Markey. Mr. Markey. Mr. Markey votes no. Mr. Barrow. Mr. Barrow votes no.
Have all members responded to the call of the roll?
Mr. Ross. Mr. Ross votes no.
Clerk will tally the votes. Clerk, ready with the vote?
Yes, sir. On that vote, Mr. Chairman, there were 23 ayes and 35 nays.
23 ayes, 35 noes. The amendment's not agreed to.